start. So good afternoon, everyone. Hope you're all having a good day. So firstly, thank you for coming in for yet another one of our expert talks. I know a lot of you are regulars here, but for people who are new, this is a monthly initiative that is run by our organization, wherein we try to bring in experts to initiate discussions around mental health topics. So a little bit about myself and the organization. I'm Sindhu Shri. I'm a clinical psychologist in the Green Oak Initiative. Green Oak Initiative is a community mental health center that provides psychiatric and psychological services. We also have been running a lot of initiatives, some of which are Samartha, our low-fee clinic, and we also run MBT psychotherapy groups, and we are open to community clubs like our book and movie club, which has a lot of people coming in. We run it on a bi-monthly basis. And we also have Chiguru, which is our perinatal mental health initiative. So we have a dedicated and a specialized group of professionals to address mental health issues from pre-conception to preschool. So I'm a part of the perinatal team in the Green Oak Initiative as well. So that's about us. So today we are here to discuss about the spectrum within being a developmentally informed clinician. We have with us Dr. Avinash Kamath, consultant child and adolescent psychiatrist, KMC Hospital, Mangalore. He has also been instrumental in running a child psychiatry liaison clinic in KMC Manipal. And he has done a lot of research around the child and adolescent population, focusing on developmental factors, sensory processing ability in children with autism spectrum disorders. And some of his publications also focus on topics like theory of mind and preschoolers, feeling unsafe at school among adolescents. So in addition to this, he also is involved in community engagements like conducting workshops, awareness programs in schools, early intervention centers, and specific to special educators, doctors in primary health centers in order to focus on screening children and adolescents with mental health issues. So thank you for accepting our invite, sir, and we are happy to have you here today. And lastly, some ground rules for this meeting. Please keep yourself on mute during the period of the presentation, and you can feel free to raise your hand or put your questions in the chat box. We'll try to address it in between the presentation, or we'll take it up at the end as well. And we would like if you can keep your videos on so that it can be interactive. And please maintain confidentiality if you're sharing any cases in this forum, and please do respect each other's opinions here. Okay, so without any further ado, over to you, sir.
Okay. I'm audible?
Yes.
Yeah. Can you guys hear me?
Yes, yes.
Yeah. Yeah. Okay. And the slides are also visible, right?
Yes, sir.
Okay. Okay. All right. Okay. Yeah. Thank you guys for having me here. So next about one and a half hour, we will discuss on this aspect of what developmentally informed clinician feels like to me, and I have not kept it so much from therapy viewpoint, all right? But I do have a few slides that are going to look at being a developmentally informed therapy, or in terms of research, in terms of being developmentally informed. But I'm looking at more in terms of regular practice and day-to-day interactions and things like that, how as a clinician that we always do interact, how developmental theories, how having a little bit background about what and all is there in psychology in terms of the developmental aspects will help us inform and why we are doing that, right? So that's going to be the layout. So, so I have kept the overall presentation quite in two of these areas in terms of giving you guys a broad introduction, and then we will look at the idea of what developmentally informed in practice looks like. Okay, so yeah, so quickly, so I thought it's all just after lunch. Most of us, or some of us, may be having lunch right now with their cameras off, but let's start off with a small poll so that I can get you guys a little bit more interactive. So the question is that, I'm skilled enough to change the child's behavior. So in that sense, I just want you guys to reflect and then rate yourselves from 0 to 10. It may in a therapy settings, if you often look at children, or otherwise it may be as parents or as anybody involved with a child, how confident do you feel that, and how skilled you guys feel that you can, change a child's behavior? So, so this is the rating scale for you guys, and then just go ahead and rate yourself. And then once the poll is completed, we will start talking about it.
All right, we have most responses. I will end the poll and share the results.
So, okay, all right. So we have roughly most people rating ourselves on 6, 10, 6, 7. Okay, so averaging somewhere around 4. So okay, all right. Okay, what if I kind of tell you guys that, if you ask me this with 10 years of experience, I will say that I can't answer this question, or I would rather rate myself 0. What you can, any one of you kind of think or say why it is that I'm saying that, I'm not skilled enough to change child's behavior. Any ideas? Okay. Now, it's the child's behavior to change. So the agency of change has to happen from the child, right? Often, sometimes we kind of presume it that, they're children. That means we are responsible for their actions in somehow, either as parents, either as therapists, or either as people interacting, right? But in whatever small experience I've had over these many years, I feel that they do have their own brains, and it's their behaviors, and so they're going to change it. So in that sense, what is it actually that we are doing as therapists or people involved in child care, right? So I would rather see ourselves as facilitators of behavior, right? As being someone who kind of helps them regulate their behavior or change the behavior in ways that is suitable or adaptable for them, right? So when we are handling a child's tantrums, or even some simple things like nail biting, the most common kind of techniques on therapy that we use are what we possibly talk as simple behavior therapy, right? So most often what comes to our mind is using BT principles, using rewarding, right? In all of that, if you really look at it, we are changing the environment, or we are trying to change the antecedent. We know the ABC analysis part, right? So we are not really changing behavior, and this is really something important for us to kind of conceptualize in our mind, is what I feel, because many times, sometimes, if we really feel that we are the sense of agency that has to cause change, we do not look at things completely in a child-friendly way or in an appropriate way. And I'll kind of give this as an example, because this was a clinical situation that kind of came to me because there was a therapist seeing this lady, and then they came to me and then said, you know, uh, what, how do we kind of follow the advice that your therapist has kind of told us, right? So uh, let's take these two examples of a tantrum, right? So uh, imagine that the child is going for behavior therapy with any one of us, and then tantrum A is like what it describes. The boy is rolling on the floor of the shop, refusing to go home till the toy is bought. He's crying and getting his clothes dirty and creating a scene, right? And the advice that the parents have kind of, the therapists have kind of given is saying that, okay, you have to ignore a tantrum because it's an attention seeking thing. Don't give him what he's asking for. Just ignore it and then wait it out, right? Now, let's look at the tantrum B, right? The tantrum B is when the child is running around the shop, he's shouting, he's crying, putting down all the toys and things on the floor, he's getting angry, tearing open boxes and throwing things, right? Would you still want the parent to uh, be ignoring, right? So, can I have a few of you kind of possibly sharing your thoughts on how would you like to handle this situation, or how would you like to kind of advise the parents? Say you're doing BT with them and asking them to anyone.
Sir, for tantrum B, I think we need to physically punish him at that time, at that point of time, and we
Okay.
have to take him out of that environment.
Okay.
So
Okay.
best that we can do is we can that change in the environment, and then we can talk to him, orally.
So you want to escalate the ante. You want to say that tantrum B, you want to be punishing the child, and then this thing.
At least
Anybody
to
else?
control his behavior, sort of a dissocial type of behavior should be controlled at that point of time. Take him out of that environment, and then explain to him or talk to him.
Let me put this child as a 4-year-old, okay, so that we don't really bring this social. But I get your point. It's not a pro-social behavior, right? Amita has her hands up. Let me hear from her.
So both are looking at attachment. One can call it as attention, but it could be an attachment issue also. And
Fantastic.
so in that space, I guess it would be about, attaching yourself in some physical form, maybe holding him, carrying him, that kind of thing. And
Right.
instead of how do you diffuse it by giving that sense of protection, attachment, connect, contact, comfort.
Right. So now you see that whatever knowledge of behavior therapy we have absolutely two ends of spectrum kind of being advised, right? Amita here is saying that we have to go ahead and kind of comfort the child, right? And she's telling let's do it in both the things. Fantastic, right? Okay, and very nicely she's bringing in the concept of attachment. Anybody else wants to add in anything? Thank you for participating in the right. So that's precisely what we're kind of looking at, right? Tantrum A, if we consider it as just a tantrum, and possibly if parents, it's a outside area, it's going to be difficult for them to kind of follow the advice anyway, right? But then in tantrum B, like what someone rightly pointed out, attachment related things are coming out, and it's not only a tantrum, there's tantrum plus affective dysregulation, right? So whenever we see affective dysregulation, we like to kind of look at it as this is actually, in spite of being a thing that is lashing out at the parents, we look at it as a escalation of the previously learned kind of a things to kind of gain more of the parental attention, and it's actually like what Amita said, an attachment behavior that the child is kind of trying to bring in. So right at that point, it is not about ignoring the child. Now, the problem is that when we often say ignore the child's behavior, that translates in parents' mind to ignoring the child. So they leave the child there. They are standing at this entrance of the, shop, and then they are not doing anything. That kind of an environment when we create for the child's attachment is going to be triggered. So a tantrum A, by following our advice of ignoring, is going to actually shift into a tantrum B if we are not careful enough. Right? So why is this happening? Because there something further is kind of getting triggered in the child. And at this point, if we kind of bring in punishment or further escalating, maybe definitely it could cause further problems in how we may end up handling the child. But nonetheless, having said that, I have to give credit to having said that the most parents or many times people would end up doing that, take him by force, take him somewhere, help him regulate himself, maybe even give a beating or two, and then kind of work on it. So why could this be happening? If you are asking, it could be an extinction burst, it could be attachment. Sometimes in children with developmental disorders, it could be sensory processing things that are happening in the environment, right? We could again sit and hypothesize from case to case basis why this is happening. So in that sense, what I sometimes feel is when we initially start off doing therapies and interacting, and believe me, I have also done mistakes like this and learned from it. Behavior change strategies sometimes feel like this, right? we have a situation that the child is, nail biting, and we understand as psychologists that nail biting comes from child's inner anxieties and worsening of and self-soothing behavior. But we use aversion techniques, we punish, we say chi, we disregard. All of these actions we know only increase anxiety, right? So in the literal sense of kind of giving a brain kind of a mask, we kind of create situations for this child where this thing. So in the past, we've done this. We have seen that the behavior changes, it changes to something else, right? But that doesn't really change the underlying psychological things. And if we are really a psychologist, then we have to look a little bit beyond behavior, right? So that's where a lot of the initial discussions about, the use of developmental theory, being developmentally informed, not looking behavior just simply from behavior point of view, and those kind of discussions started happening in this thing. So that's where some of the kind of discussions that we're going to do today is going to take us. So let's now quickly spend some time in understanding development and what we mean by development, right? This could be a talk in itself, but I'm going to just say some basic things and understandings that we have on today, things and our current levels of understanding in terms of key developmental principles. I would ask people who are interested to go to the ICAPAP textbook, and there's a good chapter, hardly takes about an hour to read it, and you get quite a lot of good examples and ideas, right? So whenever we are talking about development of a child, we are talking it in terms of two contexts. There is always an aspect of how much the child brings in terms of its own temperament, the genetic loading, the intrauterine growth, a lot of aspects regarding nutrition that is available, and the inner wiring that plays out over time, that is maturational levels, and then puberty and all of that. So there is a lot of nature kind of a thing that is ingrained. And at the same time, we also see a lot of developmental theories and other things that focus on the importance of nurture, right? That, the development doesn't happen in isolation. It always happens in an interactive way, and nurturing by providing food, by providing love, care, a stimulating environment. All of these things are actually necessary around the child to kind of, facilitate that process of development in a very good way. So that's about the nature and nurture principles in basic, right? We all understand that a child, when he is developing in a timeline. So there are certain developmental timings which are important, and we know that we look at these things in milestones, in terms of motor milestones, speech milestones, language milestones, and how each individual milestones and how these milestones develop, right? And we also understand that all these milestones may not happen in the same way for each child. And in case, say, the child has an injury or a severe health condition or any kind of a problem, then there can be a temporary setback, but the brain is very plastic, and then there is always a possibility of catch-up, right? So our diagnostic systems allow for this kind of a understanding of catch-up, and we don't label certain diagnoses till a particular age. We look at giving saying things like the child is at risk. We don't really confidently make a diagnosis of ADHD before 6 years of age, right? So some of these kind of things that we kind of take care, even when a lot of symptoms and problems may be present earlier on, kind of just tells us that there is a lot of plasticity in the brain, and there is a lot of timing at which different things happen, right? The brain doesn't develop all at same time or simultaneously, right? There are sequencing, and then there are variations in development, right? So this kind of a sequencing and variation is something that is very integral in development. And in the last 10-15 years, we have spent quite some time researching regarding the things about sequencing, variation, the impact of having a second language, at what age, right? So you will find a lot of very good literature that kind of looks at when is the best time to introduce new languages to a child. Should we kind of keep a single language for a child, or should we keep more than one language for a child? What happens if parents are raising a child in a multilingual environment? What happens when the child is when an adopted child comes to an environment where the language is different, right? A lot of these kind of interesting questions have been asked, and we have looked at how the sequencing in general is and what are the variations, right? So we have a lot of answers now in terms of how this sequencing and variations in development happen. So it is not only enough to kind of understand saying that, these are the red flags or a thing. So these days, especially in private practice, we see those gray areas. We see those people who are not really yet at a diagnostic range. So understanding these small variations and looking at why these things are affecting is becoming more and more important, right? The another important key principle in development is what we call as critical and sensitive periods, right? So critical periods mainly for language and speech development and acquiring certain skills, right? So we know that in case the person is not been hearing or is having some kind of a speech delay, then we know that by 6 years, if the child is not stimulated adequately, then the chances of the child being able to speak, especially in, say, if the child has some developmental disorder like autism or has any sensory impairments and things like that, there are critical periods that after which the development will not happen, right? At the same time, there is a sensitive period wherein which the maximum kind of development kind of happen across time. So there's a lot of understanding about this criticality and sensitive periods, and we understand that this is because of the myelination process in the brain, right? The brain doesn't myelinate all at the same time. Whichever areas of the brain get utilized during development, and as the myelination is happening, the critical and sensitive periods keep on changing, right? A lot of work has currently happened in terms of culture and context of development, right? We now understand what trauma does to a developing brain. We now understand what physical and functional changes can happen in network connectivity and in this thing when the child deals with severe trauma. So a lot of context around which the development happens and the variability is being understood, and also what influences culture have, right? So there's a lot of studies that have happened over the last few years on that. So I would like you guys to kind of go back and take some time to read some of these things and understand that a lot of interesting theories regarding the role of mirror neurons in a lot of these developmental disorders, how some things like how the mother and child interacts and what happens when the mother and child interacts, what is the scientific things happen when you do a peekaboo game with the child, and a whole lot of these kind of studies have been really looked at even in experimental context and otherwise to kind of understand development in detail, right? So what it means to look at things from developmental lens is that there are these 5 things that I feel that come, in being developmentally sensitive and understanding things from a developmental lens, right? So these 5 things are understanding that development builds on itself, that you are sometimes your own reference. We need to look at how that individual was in the context of his own development and then understand what is happening, right? Also understand context, and that a lot of times context influences development. We'll get a few examples of this. Understanding that development is transactional, meaning to say that there is an interaction between 2 individuals minimum, that is the mother-child unit or the caregiver and child unit, right? So there is at least a two-way interaction that is very strong, and patterns of problems, and this is where most of our psychopathology lies, because all of our psychopathology in adulthood is patterns and development and other things that have happened over childhood time, right? It's not like suddenly one day an individual is having certain kind of personality traits or things like that. They have evolved from temperament, they have evolved with the individual coping with the environment and the effect of environment on the individual and a lot of other things, right? We also understand that the first 5 years are very crucial in development, and in the first 5 years the brain is developing very rapidly. Not that after 5 years development stops, right? Development happens in case, if you actually look at current literature and you see till when the brain takes to myelinate, it takes about 21 to 25 years to myelinate to an adult level, right? Sometimes even longer. So we know that there is very high variability in how each individual develops in the first 5 years. And there is a lot of malleability, meaning to say that if there was a deficit and if something has changed, like for example, say a child actually has some kind of a motor deficit in terms of a say a, equinus or a orthopedic deformity, because of which it needed to be put into a correction and the child's motor deficits actually delayed. Because of the motor deficits being delayed, there's a likelihood of the speech and cognitive things also falling a little bit behind, because this child is not able to go and interact with the world like other children do, right? But in a critical period, like say 2.5 years, 3 years, if the motor thing is corrected and the child is actually mobile, then actually the cognitive milestones also completely improve, the speech delays also kind of completely disappear, right? So there is a lot of rapid change that is possible, and the learning that systems that are intact do help the child catch up on a lot of milestones later on if one of the milestones is holding or pulling the child back. So these are some of the things important to keep in mind when we are looking at it from the developmental lens. So let's look at each one of some of these things, right? So now we understand that about 15-20 years ago, when we initially discovered regarding the potential of finding genetic causes and things like that, we kind of very simplistically said, saying that yes, we now know genes, within no time we will be able to figure out what causes a whole lot of things that we don't have understanding for. And we now understand that unfortunately that is not the case, right? So we have genes that are involved. There is gene environment interaction in form of epigenetics that is involved, and then there are environmental factors, right, that influence development and how the things goes along, right? I mean, let's take simply a clinical presentation, right? Like for example, if we take a 5-year-old child, right? Let's imagine saying a 5-year-old child is there in our clinic. He's running around. He's saying he's a Superman, and then he's jumping, right? I wouldn't pathologize it, right? If I have a 15-year-old child doing it, I am thinking of at least 3 or 4 diagnoses in my mind, right? So just that age and whether it is normal for that age or not, right? And what has happened, right? So what we need to understand is that being psychologists and dealing with people with these kind of a developmental issues, it is not only normal according to age or what is culturally accepted or okay, right? That's one kind of a normative kind of a thing to look at that we often commonly do. We also want to kind of look at, is this normal given this person's history, right? For this person's history, like the seizure disorder that this child is having, like this other additional problem that this child is having because of physical health, or it may be because of something that has happened in the environment of the child. The child has had a loss of mother very early on. Can we then also understand this problem, right? Or is it like a completely non-normative thing that his experience is completely different from norm, and then we don't know how to kind of assess it? So and there are a lot of these kind of nuances that we can see in terms of how the development happens. So if we kind of take this kind of a clinical example for us, right? So a child with ASD currently, let's say, comes with the seizures at 6 years of age. After the onset of the seizure, the child, again started having bedwetting, irritability, and currently the child refuses to go to therapies, right? The parents report that they are worried that they will lose their learned skills, and we're hoping to send the child regularly to school, but currently they are not sure anymore, right? So can you guys kind of now, one of you just unmute and tell me what they feel about a case like this? What do you think possibly needs to be done for planning anything for this child? Am I going too fast?
Wait, ASD stands for?
Autism spectrum disorder.
Sir, I think first we have to treat the seizures, take
Right.
child into confidence,
Right.
then we can continue with the therapy.
Right. But the child is refusing to go to therapy now, and bedwetting has started again. Some behavioral problems. Yeah, I mean, what you're wait
Can
and
we do
watch. Once the
in-house therapy?
seizures get better, the child may again start going. Okay, can you do in-house therapy? Right. Okay. Any other thoughts or ideas? So, what I'm kind of using this case for you to understand is, there are three things in this case now. One is that the child had a kind of developmental seizures happen, right? 6 years of age, right? Now, at 6 years of age, if the child is developing seizures, and this is a child with autism, and some bedwetting and some refusal and irritability has started, does it raise in your mind worries about anything else? You may want to know whether there is possibility of regression, right? You may want to know whether if there is a possibility of regression, are we dealing with somebody who has something more missing in the picture? Are we dealing with a neurodegenerative condition?
It
Right?
could also be trauma, right? It could also be
Yes.
trauma related. It could also be
Yes.
environmental changes of
Yes.
schools, changes of some interaction in the social space.
No, here for simplicity of the case, I have written saying that it's seizures. Right? Seizures we all more likely than not understand is a biological entity, right? In terms of epilepsy. Right? And let's assume for simplicity's sake that it is after that this is happening. Right? There could be. I'm not saying that this child wouldn't have been possibly traumatized or that may not be playing a role here. But then I'm just saying when one factor comes, how it kind of influences. So in this case, we now need to have a baseline of what and all the child's functioning was till 6 years. Seizures, how long the seizures have had, what kind of seizure is it? How is that seizure affecting this child's development? We know that some seizures can have dyscognitive symptoms. We know that some seizures can be localizing, and that means that the child can have attentional problems coming up, hyperactivity and other things starting, right? So we now see that, we need to have a baseline till 6 years, then what's happened with seizures, and then we have to kind of pathologize. That means to say that using the child's own reference, I need to be able to kind of help these parents over the next few months to kind of figure out where the child is losing out, what are the learned skills that the child may lose, what can be attributed to seizure, is there something else that is required to be evaluated or not. So we just see that by one single change in the child's history, the framework in which the child gets evaluated changes quite a bit. So that's what I want to kind of understand when I'm saying that development builds on itself, right? So it is all the child's baseline that I'm interested in. What is the child doing at 6 years that the child can do? Because we know it's not all children with ASD are not the same, right? So what are the baselines that we need to look at and things like that, right? So the second thing that we will now look at is context that influences development. Now, I'm going to spend a little bit time here because I feel that many a times we look at behaviors and we very immediately look for solutions in behaviors, like what I already gave an example for. So, what is this context, right? If we take a child's mind, we kind of conceptualize any mind in terms of a cognition, emotion, and behavior, right? So these are the three main areas. And then whatever symptoms we have, we kind of look at whether they are cognitive symptoms, whether they are emotional symptoms, whether they are behavior-related symptoms. And we know the cognitions influence behavior, behavior influences emotions, emotions influence cognition. We know all of those things are interrelated and happening, right? But it's also important to understand that this is happening in a context and environment, right? And this context and environment may be something that is traumatizing, maybe that is something invalidating, maybe that is something good, maybe that is something different from what the child is used to, right? So a lot of changes in context will definitely change these things. Something just like simple, like if there is a loss of job that happened during COVID for many people did, families had to relocate, right? And they relocated with the child, right? So for the family, these are adult decisions and things like that. But for the child, there is a lot of environmental change that are happening along with it. Has the child been prepped for it? Is the child ready for it? We don't really know, right? So that can sometimes cause worsening of anxiety, can cause things. So, that's why I'm saying that it's not only these cognitions, emotions, and behaviors and understanding the developmental thing, but actually focusing on the history of the child, which kind of tells us cues to what are the environmental changes that have happened, right? Now, this is where working with children is a little bit more complicated, right? So we have not only one mind and context to deal with, we have a minimum of 3 minds and contexts to deal with. In Indian context, there is a grandmother, there's a grandfather, there's a lot more context in place, right? So in that sense, the picture actually looks like this. In a minimum situation, we have a family unit, right? So there are forces from within, there are forces from without. So there could be direct effects like sibling rivalry, right? And I'm not saying diagnosable sibling rivalry, but I'm talking about sibling rivalry as a developmental construct, right? Say for your luck or bad luck, you had a sibling who does fantastic in education, right? Just because that child is doing very fantastic in education, your trajectories are also going to change because parental expectations do not change only for one child, right? So then they want the same thing for you. They're doing the same whole lot of things for you, and imagine by the chance of bad luck, you have something like a mild amount of LD, right? So are your parents going to understand with the same kind of a simplicity? Is the comparison not going to happen? Is that not going to play out in your lives, right? So there are these direct effects that can happen in because of one-to-one interactions that are there. There could be indirect effects like what we spoke of, right? There could be job loss, change in school, uh, you know, behaviors that happen worse during vacations versus school time, right? So there could be a lot of environmental factors that need to be kept into play. Like, for example, one of the common environmental factors that I have to deal with often is if the parents are coming to me during vacation, can they come back to me for continuing the help with the child after vacation is possible? If that's not possible, then how do I translate whatever work that I have done to, be useful for this family, right? These kind of things have to start planning right in the initial part when we are dealing with the families itself. Otherwise, what happens is we think, okay, we will start. Then somewhere down the lane, it doesn't really happen. So the change doesn't really happen, right? So I quite find this construct of ecological systems theory very, very useful, and in conceptualizing or prioritizing plan, I take quite some time in looking at all of these environments in terms of planning what may be possible for the child. That may sometimes mean even choices of medications may change because of these kind of variations. Like, for example, if a child less than 6 years very clearly has ADHD but cannot really come regularly for follow-up, I will not start the child on methylphenidate, right? I may start the child on something else, but I will not give methylphenidate, even though I know that methylphenidate is what is required for this child, because if the frequency is too infrequent at less than 6 years, I will not be able to adjust the child's medications and things like that in a good enough frequency, and they are more likely to kind of, either drop out or feel that the doctor is overdosing the medications and stop the medication. So, these kind of adjustments that you need to do happens not because of any learning in psychiatry, but they happen because of how these various systems kind of interact with each other. So let's take a few examples of this, right? Language delays in multilingual parenting. I don't know how many of you guys have witnessed these kind of things that we see. More often than not nowadays, we see families which have multilingual parents, and parents are, one parent is different, talking a different language, and another child is talking a different language, right? And we see when this is what is followed and parents are interacting, there may be a mild delay, right? So this is an example for how the microsystem kind of takes in place. Now, if they are very cautious about this delay, nothing much to worry as long as there isn't anything else that is impairing the child, right? But if you have a multilingual parent along with a child who is on the spectrum and is having a speech delay, then comes the thing of kind of maybe telling them, saying that, what, for the child, till the child picks up a one language well till about 4.5 or 5 years of age, let's do predominantly things in one language. Which would that be? If it's in an urban area, maybe we can keep some of it as English. Maybe we can keep some of it as, so these kind of discussions and negotiations that happen because of these kind of interactions, right? School refusal after recovery from a surgery, right? So a common context that we often see in situations is that the child may not have actually much problem or other things, but after having a major injury, which can be conceptualized as trauma, right? And then possibly surgery, and the child is not okay, and then that kind of brings about some of this attachment related concerns for the child, and then the child wants more attachment from the parents and is happy about the right. So when these kind of things happen, school refusal may come, right? So actually, is there something axis one in this child to kind of deal with? Should I kind of go about and saying that this child is having separation anxiety and all of that? If you strictly go by criteria, most of the cases that come to us may not really fulfill this axis one criteria. But understanding developmental psychopathology will help us work with situations even when we don't have an axis one situation, but it is causing disruption, right? See, what happens is the moment there is a school refusal in a family which has both parents working, they are very highly likely to get them to a psychologist or psychiatrist for help. Why? Because it is loss of revenue for at least one parent. And that means that the parent has to sit with the child when the child is not going to school, right? And that means very high likelihood of getting too much attachment from the parents than what is possible really by the system means that, you know, a whole lot of things. Sorry. start becoming unsure. So we see how certain things can really change, and that may not be anything to do with the how we conceptualize psychiatry illnesses, right? So in the same way, we can have change in scope. Like, you know, are we whenever there is a you know, we see this often in our cultures here. Parents who have children in bank or transferable jobs, when they move from one state to another, when they come to a new state, especially if they come after third standard, fourth standard level, they have to start learning a new language right from beginning, right? So that induces quite a lot of stress on the child in terms of learning a new language, and this can become a example for how the exosystem kind of plays a role, right? Now, there is also a very interesting system that we often ignore and we don't look at, that is the chrono system, right? And chrono system is the system of time, right? How time conceptualizes various things is different. How we conceptualized homosexuality 50 years ago and how we are conceptualizing it now is different. How we are looking at gender diversity and things before and now it is different, right? So what are the experiences that were there in literature 50 years before? Can they really tell us how the effect of it is in the current system? Definitely not. So we are in this chrono system, especially with the technology and other things, we are getting rapidly outdated with our literature, because literature doesn't really have the time to catch up with how rapidly the time systems and things can change, right? So one common experience that many people often share is that, you know, these days looks like every 5 years is a generation gap, right? Whereas previously it was maybe 10 years, 15 years, right? So imagine you are a gender non-conforming child, and with the access to technology and information, how that child has the life in current generation versus how it would be a few years ago would definitely be quite different. So, you know, this is where actually a lot of what do you say, contextual differences start coming in, even in very well literate parents having to deal with the children who are having any of these kind of problems and things going on, right? So conceptualizing it using this kind of an ecological system helps us in our mind to kind of understand, saying that it may not be actually anybody's fault. There are a lot of things that are interactional. It is neither my fault, neither my husband's fault, neither the kid's fault. It's the interaction. It's a part of life and how life influences change, right? So in that sense, development is transactional, right? So there is a lot of research now that kind of tells us regarding why you know, it is important to look at development in a transactional way, that it is not only the child developing in an environment, but what the parents are doing. If any of you are interested, they can look at what this mother is, and then, you know, how there is a lot of importance in language development happening, and attachment, and, you know, eye contact and other things improving in terms of parents being animate and being able to interact with the child in a baby talk kind of a fashion. And it is not simply that automatically we start, you know, baby talking with the child. There's a lot of and interesting reasons why we do that. We don't talk to the child like what I'm talking to you guys right now, right? So there is a lot of reasons why that happen, and the parenting styles are mediated, and then there's a interaction, right? And this is very interesting. Even in twins, if you guys have seen, they will say that even identical twins, how one child gets suited versus other child gets suited is different. So it is not that parenting styles are fixed. Parenting styles get mediated onto the child's variables also. So this goodness of fit kind of a thing, and understanding the transactional nature of this is also important. In clinical situations, how do we see it? One common thing is effect of screen time on children these days, right? We talk about how there is things of speech delay, whatever, virtual autism and things like that, right? These things can affect, like say for example, toilet training. If both parents are going to work and they are spending more time putting the child on diapers, the toilet training can actually get delayed, right? Like for example, I have two nieces. One of them in a very urban area with both parents working, another in a situation where they are at home and one of the parents is not working, right? And both of them are roughly, similar times, but the one wherein the mother was not working had time to allow the child not to be wearing diaper at home, or was using cloth nappies because they had the time to kind of wash them. And then that led in this child learning toilet training quite earlier, right? I'm not saying that the other child is delayed in toilet training. Okay, I'm not saying that, but this is just an anecdotal observation of how some of these changes in environmental things can bring about major changes in how the child becomes independent in terms of toilet training. So while right in the beginning of about 1.5 years, one child is toilet trained, the other one is about 2.5 years and still uses diapers and this thing. None of this is abnormal, mind the way, right? So we are not yet talking about diagnoses, but when we are saying that, just give me 1 second. Yeah. We are saying that these things do matter, right? So language exposure can vary. Similarly, broad autism phenotype and how that affects, right? We do find that a lot of parents who are having children on the spectrum, they are not animate in terms of interactions themselves. They have what we call as a broad autism phenotype. They don't express themselves verbally or this thing so much. So the amount of voice and interaction that the child gets is also less. So there are these kind of additional impacts that kind of add on. So we do understand now that there is a lot of interactional value in development, right? And imagine if some of you are working in perinatal psychiatry, so you guys will very clearly understand how the need for bonding and other things is very, very important at a very young age, right? So we need to be able to look at what is the effect of influence of the parental mental illness, right? So these are definitely going to happen. So because there was a question that was asked on virtual autism, I thought I'll spend a minute on that. I don't believe in this construct, okay? But then often when I have seen children with speech delay or having some autistic symptoms, this is the kind of milieu that I have seen in, right? It's often a migrant child, and in the sense that the child has migrated, maybe an Indian who has migrated to Gulf countries, or there is a significant shift in the early atmosphere, or a lot of these cases started being seen in the early pandemic time, right? Just after there was a lot of change in job-related environment, job certainty, and things like that. The common situation possibly between all of those things is a perceived relative social isolation that is there. Parents find it a little bit convenient to let the child be with the device because that helps them do other things at home or things like that. So initially they feel it is good. They even pair it with activities like eating or things like that, which we know is very good in conditioning the child. And then there is a link that the child and the device happens, and the child spends hours in front of the device, and then we see behavioral problems, we see hyperactivity, we see speech delay, all of that, right? Now the same kind of expressive speech delay can also be seen with neglectful environments where the family is not able to provide and things like that. But I am yet to see one single child who has full autism only because of this, and then we have done this, and then the child is completely fine, or there are no TOM deficits or things like that being present. Okay, so it. But what I rather feel is that there are some individuals with autism, they themselves have an inherent tendencies that they may spend longer time in terms of playing with repetitive things, and children with autism are known to kind of play for hours together and end with toys, right? If you see how children with autism interact with their screen, that is different from a lot of other children. A lot of children, if they're spending quite a long time, they will finish one video, then take a break, then go to the next video, or they'll keep on going between one video and another. A child with autism, what the child likes in that video, will want to see that video again and again, or will finish that video and ask that video again to be put. So for months together is not at all tired of a rhyme, is always insisting on that same rhyme at the same time and wants the same things to happen in the same way. These are core autism phenotype, which is kind of interacting with the screen. So when you change the screen environment and interact more with the child is going to speak more. But has that caused autism? I frankly believe no, right? We do see more and more high functioning autism out there these days. So the deficits in a lot of children who have autism is not so severe as what we used to see before. Maybe because of good obstetric care, maybe because some of these cases are because parents are having children later into their lives, and we know that increasing parental age is a cause for a higher chance of autism, right? So all of these things may be playing in back of the mind, but then a lot of literature and a lot of articles we see, and a common question that I get asked is on virtual autism. So I thought I'll spend some time here for you guys to understand how I understand it. So to me, that speech delay that is happening is because of some amount of neglectful parenting, because it is becoming convenient for the parent to keep the screen and get the child to eat or be there. And it is not that is causing this thing. But independently, screens these days may have some effects. We still don't know in literature. We will take some time to kind of possibly know more about this, right? So with that take, I can talk a little bit about quickly about patterns of development and attachment styles, right? Now, this is where a lot of your developmental psychopathology is, right? If you read about developmental psychopathology, understanding personality concepts, understanding adult psychopathology by looking at child interaction variables and all of that, this is that, right? So patterns develop over time. There is a bidirectional role, attachment styles and things like that, right? So there's a lot of research over this. And what are the clinical implications of that? We need to be aware of these interactions when we are working with OCD or child, right? So when we are working with ODD or conduct disorders in child, we need to understand that these behaviors didn't come just like that. There have been interactions between the gene and environment and things, right? We'll see effects of early parentification in terms of how that has an effect on development of personality variables, right? And we also understand that dysfunctional family systems need to be addressed in handling externalizing disorders. If you look at current ADHD literature, lot of importance being given to family interventions, family work, and that itself becomes a major part of working with the problem, because unless you deal with the family dysfunction, whatever attentional problems and other things doesn't really come to a good level where we can start working with it, right? So the importance of working on dysfunctional family systems in externalizing disorders is very well known these days, right? And we also understand the development of personality traits, right? So this, I think I have already told right in the beginning. Like now, for example, when we talk about developmental disorders, right, and GDD or this thing. So we give a timing of about till 5 years before we call that a child has a global, intellectual disability, right? This is because of this kind of a rapid changes that is possible, right? What has changed though over the last 10 years is, we would say wait till you get a diagnosis and then do intervention. Now we have said no more wait and watch approach. If there is delay, we change the environment suitably for the child. And what is now happening is, can we do this rather than in a very, what do you say, very strong behavioral way, like what ABA and other people kind of are criticized for doing? But can we instead do it in a developmental way, that the child interacts with us through play? So can we use play principles and can we do it with play, right? So that's where the current focus on terms of using play in neurodevelopmental disorders is kind of coming in, and I think that's quite interesting in a good way of looking at things, right? So to sum all of these things up, I think we already have enough literature to kind of tell us, especially everywhere you will see about adverse childhood experiences study, right? And you know that these developmental factors, genetic things, are not only responsible for psychiatric comorbidity. Psychiatric comorbidity is one among the comorbidities. They are involved in chronic illnesses, cancer, other disorders of the heart, hypertension, right? How adverse childhood experiences change the risk factors in the brain, which cause changes in the wiring and biology, and how they kind of influence chronic diseases is being studied now. Psychiatric disorders, we have always been studying how it can impair cognition, how it can influence things like obesity, how it can cause problems like alcohol, tobacco, and drugs, how high risk behavior can become because of early sexual experiences and things like that, right? How it can result in crime, increased poverty, and then of course transgenerational effects and problems, right? So in that sense, understanding developmental disorders well, or I mean not developmental disorder, understanding developmental theories well, help us understand that we are not only dealing with the psychiatric illnesses, but then there is a lot of complex multifinality and equifinality kind of effects that we look at, and we are looking at mind, body, and the link between. And this kind of really highlights that there is a lot of interconnectedness, right? So this is roughly the kind of thing that I wanted to talk to you guys about. The things now. The next part is going to be a little bit more interactive and less theory intense, and that's where we're going to take a few examples and things. But I can take a minute's break here, and in case you guys have any pressing questions, I can take that. I was told that we would prefer to have more interactions than the talk keeping last so longer. So in the next 10-15 minutes, I'll try and finish off rest of the slides. But in case you guys have any questions, we can take it this moment. Okay. Any questions in chat? No, right?
But Kapil has raised his hand, I think.
Okay. Okay. Yeah, Kapil.
Hi, sir. Good afternoon.
Hi. Nice to hear
Sir,
from you.
I am not working with children much, but when we see adults, we see a lot of, we go into developmental history to understand where the problem started, what may have contributed. One thing I'm seeing recently, and I wanted your opinion about it, is sometimes we see adults who have maybe a neurodevelopmental problem. They're showing clear symptoms of it in adulthood. But when we talk to parents, we're not seeing as many symptoms or signs. Sometimes I also see a lot of clinicians hesitating in diagnosing in adulthood if there are no signs. They would rather just say it's not there, or give sort of a provisional diagnosis instead of saying it's actually a problem. And work with the symptoms, no diagnosis, but work with symptoms. So I just wanted your opinion about it, and if you've seen sometimes.
Can you be a little bit more helpful to me by saying what diagnosis that you want me to kind of focus on?
Both ADHD and autism spectrum disorders.
Okay. All right. Okay. So what my take on it, Kapil, is that at one end, the concepts in terms of especially ADHD, in terms of adult ADHD, is quite new because the diagnostic system has itself been changed in that sense. So whom they are going to for this kind of evaluations and things will vary. That is one thing. Second thing is, many a times when we make a diagnosis, like for example, if you ask me today, how much time will I take with the client to actually confidently make an adult ADHD diagnosis in a situation like what you are saying, right? Where the person is, say, um, having a lot of other issues along with wanting to identify or wanting to possibly conceptualize the thing as a adult ADHD, and where you're saying that the parents is not kind of telling the same things that what you want to hear, right? This is common these days, and one of the reasons why I feel is that because there's a lot of awareness about these disorders, and that kind of helps them think that, see, all of our psychiatric diagnoses are based on rating scales or questionnaires, right? While we are aware of that, we also need to understand that these disorders are developmental in nature. So it takes me sometimes even up to about 1.5 months of interacting with an individual, talking to them, looking at their dysfunction at multiple levels, right? The important thing for you to understand about ADHD is that the problem should not be limiting to one single dimension, right? Many a times for a lot of them, the problem is related to interpersonal dimension, or it is limited to dimension which is involved with work, right? And this is because of a developmental trauma or a developmental problem or a anxiety disorder comorbid or a depression disorder comorbid in their adolescence, and they have recovered from the depression or thing, but then the cognitive symptoms are not completely better, or there is some other thing that is coming along, right? I also have the same kind of a problem that you would have, wherein which it is okay when we look at symptoms on outside and say, okay, looks like you possibly having ADHD. But if I ask the parents, that's not working out, right? That's where the literature is also kind of looking at it and then saying, okay, maybe some of these ADHDs do not really develop very early on. But in my experience, what I feel is a lot of trauma, a lot of other developmental variables into adulthood can present with same kind of executive dysfunction, right? Ultimately, it is that executive dysfunction that you want to get better, that they are not able to plan properly, they don't know what to do, right? I'll give you a simple example. If you have seen children who are taken care by parents who are doing a lot of helicoptering, right? A lot of these children will have these kind of deficits because till their adulthood, till they are simply launched, they have not had to deal with any adult related decision making. Then you simply launch them into adulthood. Then they are having relationships. Then they are having a whole lot of things. So there is a sudden jump in their lives on to taking a lot of adult roles, right? They have not been allowed for that at home. They have not been exposed to those kind of understanding of things, right? So when we see that, the parents are like, no, he was completely fine. He was doing fantastic. I don't know what happened when once he went to college. I don't know what happened once he went there, right? So you'll see a lot of these kind of discrepancies. What that kind of tells me is that this child was always given whatever was required without really having small kind of places for the child to kind of develop that. So, these are some of the things that I kind of used to kind of conceptualize the kind of confusion that happens with adult ADHD. And it's difficult because I have had situations where people have said, doctor, I have ADHD, give me methylphenidate, right? 25-year-olds, 30-year-olds seeking out saying methylphenidate is the solution for their life, give it to them, right? So it does take some time, and if they are patient, it has worked positive, but I also agree that sometimes it's not. Does that answer your question? Yeah. Okay. So let me look at quickly at developmental theories now. And at this point, I encourage more and more questions can keep coming as they flow, right? Now, for people who are not really read, this is a very good introduction. You can just take the CTP, that is Comprehensive Textbook of Psychiatry, 2 pages, spend some time there. You will understand a few things about interaction and things like that. Then you can go about and read. We have multiple theories. I'm not going to really spend time on each of these theories. Okay, not really possible. But then all of these things inform our current practice in terms of understanding developmental theories, right? And we have not stopped at that level, right? We have now looked at how these influences, because each of these theories are not perfect in themselves. There are limitations. There are things that we need to understand till where we can understand them. And then there are debates about taking these things towards meta theories, right? So this is a good article that I found for people who want to just start reading about these things, about models of development and theories of development by Heinrich. There are definitely much more extensive books and material available, but then I'm just giving you some place where you can do a start, right? And in the 1970s, these discussions were happening about whether there is continuity versus discontinuity in development, whether the development is something mechanistic or whether it is organismic, right? Whether it is holistic, elementary. These are very, very wonderful constructs. You can take quite some time in talking about them. And we know about Michael Rutter, and he has written a very good article about how this developmental psychopathology concepts and challenges, again, about how we understand these developmental constructs in current day. So I will now spend a little bit more time in terms of sensitizing you to clinical situations, right? So a lot of developmental theorists believe this statement. So I want you guys to read this statement, and we'll have a poll here to look at what you guys feel. Okay, so just everyone, just take a minute to read this, and in the meantime, you guys can help me in the back end with the poll. Psychotherapists must consider the role of parent symptoms as well as community and culture within which the child is raised when interpreting symptoms. Once developmental and trauma-related hypotheses have been adequately assessed and ruled out, then only should professionals consider pathology and mental illnesses. Okay, this is a strong notion that a lot of people do follow, that if it is trauma-related, if it is related to, say, this thing, then we need to deal with it differently, and we shouldn't pathologize this. And there is no pathology or mental illness involved. It is just only developmental, and it is trauma reaction. We help the child deal with it. The child will be better. So I would like everyone to kind of give their opinion on this. What do they feel? Completely agree, neutral, disagree, completely disagree. Are you understanding this? Are you guys with me? Okay. So once it's done, I request you guys to.
Yes, we're
Simple?
just waiting for others
Yeah.
to respond.
Yeah. All of you can see the poll screen. Okay. All right. 36% of the people have completely agreed with it. 27 people agree. 27%. Okay. So we have almost a split house. 27% disagree with it. Wow. Interesting. In 20 people, if all of us have kind of rated, that's truly a split house. Right. Okay. Okay. Would anyone like to, anyone who's given the either side's answers care to unmute and talk about what they feel about it and why do they passionately feel about it? Anyone? Anyone who completely agrees?
So I completely agree because
Right.
I think the first half where I think you have very well communicated that it is a mix of many factors that leads to a child behaving the way they do. And so those factors need to be taken into consideration. And I think you've covered that pretty well in the first half itself. And that's been convincing
Yep.
for me and also
Right.
in my own experience of work. I
Right.
feel it is important to look at,
Right.
environmental factors, interpersonal factors, all of
Right.
that before
Right.
you go into this pathology or diagnostic kind of
Fantastic.
process.
Fantastic. Thank you. Anybody who completely disagrees? We did have quite many people who said completely disagree, sir. At least 4 or 5 of us completely disagreed with it. It's not wrong. Okay, we are not dealing with absolute wrongs here, so don't hesitate to kind of say. This is where I'm going to kind of twist the scenario actually to kind of help you guys understand, right? What I'm telling about. Okay, so
So I think couple has
if
his raised.
yeah,
So
go ahead, go ahead. Yeah, I cannot see raised hands for some reason. Yeah, go ahead, Kapil. Yeah,
Right, so it's a very difficult state actually to say completely agree, completely disagree. But for me, it would come down to what the use of the pathology would be. If the pathology means that the system comes in and we try to change the system, I would diagnose and say, yes, it is a pathology, and we need to understand the reason and then go into the developmental and the traumatic part of it.
okay.
But if I initially say, no, it is not, and I don't know how much utility. That's where
So,
we came out also, right? Like
yeah,
phenomenology was easier to understand, and that's why
right.
we took that. It was too
Fantastic. No,
difficult for people to understand.
yeah. I think you're raising a good point, Kapil, there, right? Okay. So I kind of compare because I'm from a medical background. I kind of compare this as something to what possibly we do as going to dentist. All of us have gone to dentist, right? We have gone there with a dental pain that was a symptom because of a dental pathology called caries, and that needed to be fixed, right? Yes. Okay. If we take a parallel from that and look at our things, right? If we consider some of the manifestations of problems, something similar to that, and say, yeah, it's kind of painful. Unless I go to a dentist, it's not really possible that my pain is going to disappear altogether, right? Right. So what caused that caries? My eating habits, right? What it requires is a tooth extraction. So should a dentist then saying that I will treat your dental caries only and only if you change your healthcare patterns, you brush your teeth properly, and make sure you will not come to me again with a caries? Is that a practice? Is that a practicable dentistry? Then all dentists will have to refer all of their cases to psychiatrists, right? Okay, so yeah, go ahead, man.
I respectfully disagree. I don't think mental issues can be compared to
I
logical
okay.
issues.
Yes, I'll explain why so, right? I'll explain why so. See, now the problem is here like this. Why I'm telling this is I'm aware about the controversy about this, but I'm kind of helping you kind of just bridge that a gap a little bit and understand. What I'm trying to make you is I'm trying to make you forced to think you in a dialectical way. These are both truths. And the reason why possibly these are both truths is that mental illnesses, or as we define mental illnesses of today, right? When I call ADHD, when I call this thing, are behavioral patterns and behaviors. This is not an illness like schizophrenia. This is not an illness like bipolar. This is not an illness like a brain tumor causing problems, right? but nonetheless, they are causing dysfunction. Nonetheless, they are causing problems. You understand what I'm saying? So that is how they are kind of put together. So in how we conceptualize these illnesses or how we define these pathologies itself is a kind of gray area, right? So if we take a very strong this side stance saying that, we are going to fix problems only if it is above and beyond what is understandable by developmental things and things like that, then we will not call anything a mental illness, right? So that's like saying everything is because of cause and effect, and then you go to spirituality, you go to this thing and take solutions of that sort. I mean, I'm just telling in the philosophical sense that way. We do see a lot of people do that. A lot of people get self-satisfaction, they get better also, right? So we're not talking so much in terms of, answering this question, but what I wanted you guys to kind of have this exercise in your mind to kind of understand that as a psychiatrist, when a person comes to me, I look at it like how a dentist looks. So can I actually see, is there a caries here somewhere? So is there a pathology here somewhere that can be fixed? So that will get a label, right? But what that label means to that individual is completely different, right? But I am hopeful that 10 years down the line, mental illness as we see or mental problems as we see will be as okay as going to a dentist. That's what I'm really hoping at. In our own minds today, it is not so, right? When it is not so, we are going to look at each of all of those smaller details about putting a label on an individual with real importance. If we think of it as, I have a small mental health problem and there are people who will be able to help me, and that means that, just like going to a dentist to take care of dental hygiene, I need to have my mental hygiene in place and I need to go to people to kind of take help, right? If you're looking at it from a broader perspective, all of these processes will make sense, right? So that's my take on it. It's completely okay to have opinions, but I thought let's have a discussion about that. Okay. So we can go a little bit to and fro if you guys have more questions, but how I take developmental framework and pathology as is that it gives us an understanding about background common factors, can help individualizing approaches to a particular individual, which is very important, which is much more important in child, right? Can help break up and conceptualize complex clinical presentation, and can help us in understanding what the kind of individual skill levels is required, right? I would like each of you to kind of read this article by Alan E. Ivy in 1988, which talks about, and this quote that I gave you from this article, I really like this article, quite nice, but it comes from a very strong developmental framework. And there are a lot of very nice points that you could use from this in terms of clinical practice even today. Okay, so what it kind of says is that the symptom production and the level in which the child or the individual is stuck may be somewhere in form of a sensory motor problem, wherein which the person is dissociating from sensory experience, is having very severe anxiety experience physically, not mentally, panic attacks, panic symptoms, right? So then the person is coming from sensory motor area of functioning. And then there are certain kind of skill sets that we could use in terms of that. So that is more environment structuring, using some relaxation techniques, behavioral modification around that, right? So that is for the sensory motor areas. Concrete operational, we can use a little bit more different frameworks. So similarly, formal operational difference. And then they talk about dialectics being the most advanced framework, wherein which you can really talk with the individual and then kind of look at what are the kind of larger constructs and problems that the individual is having, right? So identifying client's level of functioning by understanding the symptom production is a good way of matching. And this matching should happen whenever there is, so they also talk about this importance of context. And I think I spent enough time in the initial time to kind of explain about the importance of context, right? And then we need to have point of we need to understand where the individual has kind of departed, right? So in that sense, in the therapy construct, right, when it comes to doing proper therapy, and I understand many of you guys are from that area, the developmentally informed psychotherapy needs you to kind of balance these three things, okay? in any form of therapy, we do these two things, right? One is symptom reduction, and second is skill building. And there is definitely an interaction between symptom reduction and skill building, right? We are focusing on reducing the symptoms that the person is experiencing. So there are some skills and things that we will tell that person to use, like say, for example, sleep disturbance is a problem. So we'll teach the person, how to have a good sleep rhythm, and we will have that has some skill elements, some knowledge elements, and all of that. So we'll do that, right? So that is symptom reduction. We'll also do some amount of skill building. It may be teaching them some self-help skills, problem-solving skills, whatever, right? And these skills may come from major schools of psychotherapy. We may be humanistic psychotherapy, CBT or BT. It may be psychodynamic. It may be third wave, whatever, right? So it may be the schools of psychotherapies that involve it, right? But as a developmentally informed psychotherapist or a practitioner, it's also important to understand that it's also our role not only to do symptom reduction and skill building, but to facilitate development, right? Especially in developmental disorders or in individuals who have significant developmental trauma, or in this thing, the development in the cognitive spheres, emotional spheres does get stagnated at a particular level and then keeps cycling, right? So this is where that concept of understanding the theory of continuous versus discontinuous development comes in. But it is very important for us as therapists to understand, saying that we need to facilitate the child's development, right, or the individual's development. You can extrapolate it to adults as well, right? In adults also, we do the job of facilitating the person's development, right? So this is how a developmental informed psychotherapy looks like. And what that means is, more and more, we are not working within the paradigms of a patient and clinician relationship that happens, or a therapist relationship that happens only within the framework of a therapy settings, which we are most comfortable doing. If you look at most evidence-based developmentally informed approaches, they say that alone is not enough. We have to intervene at school level. So the Head Start program was one of the first programs which talked about developmentally informed approaches. Said no business of doing it in the clinic. Let's go and do it right in the school, because the environments are different, the factors are different, peer learning happens, a lot of things happens, right? So evidence-based developmentally informed approach looks at breaking the traditions of a therapy thing and involving a lot of other things, right? If you guys have heard about one very good evidence-based therapy which is involved in areas where no other therapist wants to venture in and do things, wherein which very high-risk group of individuals, right? That is externalizing disorders, conduct, children in conflict with law out there. It is multi-system therapy. Borrows very heavily from family therapy, has multiple therapists involved, people involved with family work, people involved with the legal support system, people involved with doing changes in the environment, right? So these are the evidence-based approaches that are now finding this thing. In a developing country like India, are we anywhere close to getting these things possible? I don't know. Maybe interesting areas to work on for people and try and see. But then that's what it is, right? If we are developmentally informed, we are not only looking at from what I can do, but what also has to happen in the environment, right? So that is what I am understanding from developmental theories in terms of how we can take it further, right? So in that sense, the spectrum within is normal, variant, having deviant, dysfunction, distress, or danger. Those are the four main psychopathological constructs of problems, right? Then having a diagnosis, then having a disorder, and then having a disease, right? So within what we conceptualize as mental health, we may be dealing with completely normal individuals who are grieving, who are having problems or things like that, right? We may be dealing with normal variants, right? They are having some, mostly normal, but they are having some ways in which they are coping that is different. We may be dealing with people who are having neurotic or psychotic kind of problems, wherein which there is very clearly deviant and distressing symptoms. We may be dealing with a diagnostic level like bipolar, mood disorders, childhood depression, a whole lot of things, right? So that may be at the diagnostic level. It may be at a disorder level, cognitive illnesses like, dementia presenting early in childhood, or it may be major illnesses or problems, right? It may be a disease. It may be, for all you know, like, for example, some of these autisms are actually diseases, right? Like they are neurodegenerative conditions, right? So if we are seeing a child with, say, a lysosomal storage disorder or things like that, we may think of it as autism, but then underlying to that thing is a very clear disease which has its own course and prognosis, right? So in that sense, we are not dealing only with one particular entity, and we are dealing with a huge spectrum within. And being aware of this helps us construct and see where and what we are looking at. So this is what I wanted to kind of tell you, saying that we will always be at this kind of a dialectical discussion, and that dialectical discussion is useful and productive, and that is how most of the work happens, right? We are looking at developmental theory versus clinical approaches. We are looking at working without access one diagnosis, especially in childhood disorders, right? If any of you have read about the childhood bipolar dilemma, you will see a lot of these kind of examples there, right? Last 20 years, we diagnosed a whole lot of them with childhood bipolar, and now we have gone back to saying, no, some of these are behavioral disorders, some of these are not actually mood disorders, these are because of trauma, some of these are CPTSD, then we say there is CPTSD with soft bipolar. So you will see a lot of these kind of jargons being used, which as a child psychiatrist, I say this is all development in progress. Later on, they may become disorders or things, right? Prodromal states, again, not clear areas, right? Lifespan trajectory. Someone who we see has ADHD, then goes on to develop conduct, then goes on to develop substance. So if you are dealing with substance and the person actually has ADHD or in the background, how many adult cases we actually manage the ADHD? Not so much. We are still stuck with substance. We don't look at what's back there, right? So lifespan related trajectory and changes, and then understanding about externalizing and internalizing, right? The last important thing that I say is a lot of severe mental illnesses is possible during developmental age, right? We see severe OCDs as early as around 8 to 10 years of age, and they are really having dysfunction, right? We still don't know a lot about what happens to them when they have a serious mental illness early and what that does to the development. We look at it as illness, we give them medications, we give them therapy to handle the illness, but then we don't look so often into their developmental trajectories. And I have a lot of people who have been under treatment very earlier on. They are better symptomatically, but they are still not settled in their lives, right? Developmentally, they are completed their educations, but still they don't have the skill sets that are involved in terms of becoming completely functional individuals in the society. They are not able to hold job positions, or they still are having limitations without being clinically ill, right? So we do see this kind of effect still being present, and that is where being developmentally sensitive helps us to kind of understand, saying that it is not always illness and illness correction alone that is our role. We will have to look at it from multiple dimensions, right? So in the commonest example in my clinic, it looks like this. Okay, and I have taken an autism example because autism is one area where in which we see this kind of a diversity very commonly. The parents and support groups and parents and relatives are saying, should we stop sugar for this child, right? So because sugar is associated with increased hyperactivity, and maybe gut microbiome and other things will not respond well by giving sugar. So let us not give sugars to this child, but the child eats a lot of sugar. So what to do? The pediatrician is saying, Amma, the child is not putting on weight. Why are you not feeding the child properly? If there is nutritional problems, then you will have other problems, right? Then a psychologist or OT person is telling, oh, these are all because of sensory issues. These are because the food and other things the child is not really able to, understand, So imagine the situation at the other end of the parents, right? One person is saying one thing, another person is saying another thing. And, that is where I kind of times saying that as we are understanding more and as more and more information is being available for people to kind of understand and interact, we are sometimes ending up telling absolutely nonsensical things like it's a genetically neurodiverse, epigenetically compromised neuroatypical elephant that we are dealing with, right? So that is the blind person and elephant paradigm that I kind of leave you guys with, right? If you guys have time, we can take questions, and then I mean, we do have time. I can take questions, and I can also have a couple of case discussions that we can kind of do. But you guys have been patient enough in hearing me for quite a long time, so I can stop now and we can interact a little bit more actively. I do have some cases, but if you guys want to bring in more questions and then we will deal with this, that's fine. Whatever the group wants. We are only about 20 of us, so yeah.
Yes, sir. Thank you so much, sir, for the presentation. It was very informative. I think it was broken down to a point where it was conveyed very well in terms of like very simple terms that was used. I think I really had a few takeaways that I wanted to share, and maybe we can open it for discussion. And if there are no questions, then we can go forward with the case presentation as well.
Yeah.
So some of my takeaways, it was very nice how you started with not defining childhood or adolescence, which is like a typical presentation way, but it instead focused on how they also have agency, and we sometimes forget that, and we just put them into boxes and want them to do how we like them to do things. So I think that was really good to know, or break that barrier of like looking at children in a different way. And I think the next barrier that you broke was with regard to how behavioral therapy works, and how we have to look beyond actions and beyond behavior. I think that was also something that was nice to, in a way that we can conceptualize and take it to our population as well. I think that is what this the biggest takeaway for me was, because being developmentally informed is not just necessary to see children, but is also very important when we see adults, and how we can incorporate several of these aspects, including context, family, and micro, macro, and even chrono systems into conceptualizing the people that we see as clients in our therapy situations as well. So it was very informative, and a lot of resources that you shared, I think we can go back and read about it as well. But yeah, if anybody had any other takeaways and how did they find the presentation, they can share that as well.
Hi, I'm Shilpa.
I should.
I'm sorry, I'm traveling. I can't switch on my video. But I did have, couple of things I did take away. I think I had similar concern as Kapil, especially we see adults with ADHD and also in spectrum. It gets a little bit difficult in terms of if there is a difference in what the parents would say as how their childhood was versus how their how the client's experiences of their childhood was. It gets difficult to differentiate what the symptoms were. That's one of the things. But what helped me is the question, the poll you put up was again that was quite helpful, because I think seeing symptomatology and helping the client with their symptoms rather than getting into too much about the diagnosis. I know for a lot of us, diagnosis hold certain. It means something in terms of defining ourselves. But I felt like, if I'm going to help the client, it would be helpful to see what are the symptoms that they are presenting with, and working towards that rather than getting caught with what would it define as. So that was helpful in terms of knowing. And also what you mentioned about the executive functioning mimicking in both in ADHD and ADHD or autism and in other pathologies. I think that was little reassuring in terms of, okay, we are targeting executive functioning, but might not be from a BPD perspective or from a ADHD or autism perspective, but we're still dealing with it. So I think more inclusive in terms of our formulation was actually something that I really take away from this presentation. And I also felt like, actually formulating and showing the diagram to a patient, like, this is how I am looking at. This is the context that I am taking into consideration. and this is the pathology that we could be looking at. But what would you think about it? What lens that you would like to think? Because these are the symptoms that are present. So I think the autonomy perspective also was really, really helpful to know,
Right.
sir.
Right. So, so
Thank you.
yeah, thanks there for sharing, Shilpa. I would also like to kind of tell two more things in terms of the ADHD thing and this thing. All right. Now,
Okay.
what I do believe is that many a times, many a times, if they have self-diagnosed themselves ADHD into adulthood and are coming and seeking help, they are very likely to be right. Okay, hear me out. They are very likely to be right. Okay, but
Okay.
what is also right is that they have coped with that ADHD and they have developed a lot of mechanisms to deal with it. And if they are functional to some extent, introducing medications actually makes more chaos than actually solving problems for them, because the expectations that they have with medications are ridiculous, right? Starting medications is not going to sort their life in terms of a lot of behaviors and the planning and other things that are the executive dysfunctions and problems that continue into adulthood in ADHD. With the treatment, without treatment, a lot of these smaller executive dysfunctions, not being able to plan, being shabby, not having this thing, having problems understanding the partner's needs and other things, being impulsive, right? All of that can still remain with medications, but because medications is available and they feel that there is some magic pill out there that may solve their problems, my experience is 80% of the time they are disillusioned within about a month of starting medications, right? They come back saying, no, the side effects are not manageable, no, I'm not happy with this is not what I expected. Then what we can do, right? So I do spend, at least in my practice, quite some time explaining to them, saying that, look, ADHD has been with you. It didn't start like depression a month ago. Even though good medications are available, you have coped with ADHD. And that coping means a lot of new learning and other things that you have done over time. And you cannot unlearn that on one day, right? A lot of people with ADHD are very good with last minute things. You make them event managers, they are running around, they are very good, they will do all the event things, this thing. After the event is over, they are exhausted, right? They just simply need about few days to completely get their energies back, right? But there is a group of people with ADHD, if they take up these kind of jobs, then they will have a lot of executive dysfunction coming in and they will have problems. So it is not singular kind of ADHD, it is ADHDs, right? So the simplest example is with learning disorder, for example. Intelligence acts as a very important buffer in learning disorders. And we know that learning disorder can be present in very intelligent people also. There have been, people who have IQs of 130, 140 who still have learning disorders, right? So IQ and learning disorders are not same, right? In these individuals who are very intelligent but still have learning disorders, you will find that they develop a lot of coping mechanisms in their writing. So into adulthood, if they kind of diagnose learning disorder in them because still they have IE confusion, their handwritings are not good, they are not able to kind of do things, it only becomes dysfunctional for them when that kind of thing affects their function. Otherwise, with their laptop, with the things, they're completely fine. You know where I find these adults? I find them when they're coming with their children with learning disorders. They tell me when as I'm talking to them, growing up he had that, hey, I had that. I even now sometimes have EI confusion. I always use Google to kind of help me know what the right spelling is, right? They're all very functional adults. Okay, so uh, so having a diagnosis per se, especially a developmental diagnosis, doesn't really tell us anything much about what the person's outcomes is likely to be.
Thank you for that, sir. Actually, it's clarified a lot of things. Actually, it put my understanding in context, to be very honest. And also, what I'm trying to understand here is seeing a person from actually, then it becomes more the important that we need to see them in the context. Like, why are they coming today to me? What is the need for them to get assessed? for these aspects. And also, as you mentioned, I think having this talk, I think as a psychiatrist and a clinical psychologist, it should be like a good talk that these are the reasons that I would be prescribing medications or not prescribing medication, versus I would be seeing from a neurodivergent perspective, not neurodivergent person. So it's quite helpful. Thank you so much.
Sure. Anybody else? Yes, I come. Dr. Sai Kumar, go ahead. Yeah.
Hello.
Hello. Hi.
Am I audible?
Yes, you are audible.
Thank you very much. I am practicing counseling and psychotherapy CBT here in Chennai, and very interesting to hear your discussion.
Sure.
I wanted to know the way how you can relate LD, ADHD, and ASD. What is the common platform that you can think of in terms of understanding these three clinical entities? And if so, then what are the common strategies that we can think of which is possible? That is my first question. The second one is that how do you understand these developmental problems in Indian context? For example, the socio-cultural component that play a very significant role in the development, not only the physical or motor development, but particularly the psychosocial development. What kind of an impact it makes, in turn, making challenges, creating challenges in terms of diagnosis and management.
Right. Okay. Okay. So I'll take your first question, sir. First question was regarding what are the commonalities between LD, then autism, and then this thing. So I don't know whether you are aware of RDoC framework. Have you heard of that, sir?
No,
right?
no. Tell me
No?
this.
Okay. So RDoC is about research framework wherein which we are looking at diagnostic entities which are common across all disorders, not limiting to only developmental disorders, but developmental disorders have a specific interest in RDoC because it's understandable to kind of put them to a lot of very structural things very easily, right?
Okay.
So what I feel is common is that all of these things have a genetic vulnerability. There is a component of other reserves around the genetic vulnerability which kind of cause the gene environment kind of interaction. And then we have the clinical presentation there, right? Okay. Like say, for example, if we look at LD, autism, or in their severity, as they grow across age group, because of the interaction that they have with their environment, anxiety disorders, depression, externalizing problems, all of those things start becoming a little bit more and more common and more likely in these disorders because of the gene environment kind of a interaction that we see in all of these individuals. So if you ask me, the importance as I see in terms of conceptualizing for all of this developmental framework is actually, is there a developmentally stimulating environment enough for the individual? And in spite of that, the dysfunction is playing through, right? Often it is so because the child is not the only seat of the problem. There is family pathology as a problem. There are not essentially pathology. There are true living situations which may make, like, for example, when there is an additional demand that the child needs, the environment needs to be coping for that child's difficulty, right? So parents may not be prepared for that kind of things, or they may not have even planned for the child to be in that kind of a developmental stage. Or sometimes, life just happens, right? So in that sense, the central thing that I do is I kind of assess, saying, is the child getting enough? So how I do it is I look around the child's environment, ask in history who and all is involved with the child. Is there an additional support system? Is there something good happening in school there? Is the child actually liking one particular teacher who is kind of doing good with this child, right? So then all of them become people who are involved in my management plan, right? Because that's maximum what in Indian situation I can do. I can talk to a teacher and kind of sensitize them, saying that, you know what, teacher, this guy has some problems like this. So give him a little bit extra time. Maybe you can ask all the teachers to kind of help him finish the notes so that he doesn't have to come back at home. You know what is happening? Because every time he's bringing back notes home and he doesn't want to be sitting and writing at home, every time fights at their home teacher. Simply, if you ask the boy to complete the notes right there, and if you have some other children also, put them along and allow them to complete in school for 15-20 minutes and let them go home after that, fantastic. Parents are extremely happy. School is also extremely happy, right? Will all schools today do it? I don't know, but they still do it in our context. They are able to individualize help like this, right? So this is what being a little bit developmentally informed and what I do in terms of bringing in common parameters from the environment and then going that extra step as this thing. And there's a lot of value that our systems plays when a psychiatrist or a mental health professional is kind of telling them, you know what, there is some role that you guys can do for this child and it's about his future, right? So when you use terms like this, they are really going to buy that and they're going to do that and they're going to do that well. So having that trust, being able to kind of utilize these kind of support systems in environment, that is one major thing that we need to be as mental health professionals doing, right? Not considering that our job is living with the prescription. So that is one. Second thing that I always often tell is that we need to build resources in the community where they can get additional help, right? We are still at the disability kind of background of looking at these problems, right? We are just certifying. We are saying that let them get extra help, let them get exemptions, let them get some financial benefit from the government, and that's it, right? But is that the end of that individual's growth potential? Definitely not, right? So we need to be able to kind of be agencies where we will talk about these things in the community and then make them aware, saying that, you know, even with disability, it is possible for them to go about doing a whole lot of things otherwise, and don't look at everything from the disability viewpoint, look at it from the individual viewpoint, and then help these guys out. So these are the two additional things that I think each one of us have to do in our practice to kind of be good, because we are not able to, we don't have a government which is listening to child's concerns. Simplest example is POCSO Act, right? Very good act, not in the implementational system of our country, right? So that's how I see it.
Okay.
And your second question was?
How do you understand neurodiversity and this developmental issues in terms of Indian context with
Indian context,
yes, making a diagnosis and case management?
Right. So I think I answered a bit of both.
Yeah.
Yeah. Yeah.
Okay. Okay.
Any other questions?
No, thank you.
Anybody else? Okay, let me kind of go through one case vignette. Okay.
Yes, I think we have another
Just
5 minutes left.
5
So
minutes, yeah. Just have one case vignette. Okay. And then I'll leave you guys with that. Okay. So a 6-year boy in Mangalore was sent to the school counselor by the principal as he had been found shouting the word Sule, and then you guys know it, fill it up in your minds, right? And running behind this during lunch break. The principal got very angry and scolded the child, and the child was confused. The school has now decided, saying we should call the father who works in a bank, and the boy has recently joined the school. The school is really taking this incident very seriously, because this is the first time they have heard a 6-year-old child say that word. So your thoughts on it? What's happening here? Anyone?
Sir, I think it could be
Yeah.
something to do with environment as well. Because when I read this statement that father is working
Right.
in a bank, somebody is transferred from North Karnataka, for example. It's a very common word
Fantastic.
used there. Very, very common word.
Fantastic.
And the environment would have played a role without the child to know what it means.
Fantastic.
And sometimes they use
Right.
it in
So
a fondly way also. I have seen this
correct.
word.
Right. So if you are familiar with the North Karnataka culture, that word is just I mean, how it is used means a whole lot of things. It can mean endearing, it can be meaning anger, it can be meaning a whole lot of things, right? So it's just a term like the F word, which can mean a whole lot of things in different situations, right? So why I'm kind of telling this is that, many times what we look pathological evolves around the culture, right? And what we expect is that these children need to be able to adjust with a culture which is, we are multicultural, right? So in that sense, from what Dr. Sai was asking, that we live in a world where in which a lot of cultural interactions kind of do happen. So a child who was raised till 6 years in North Karnataka, when he comes to here, will have a lot of cultural things to deal with. North India, South India itself is a completely thing. So I am using this example to kind of tell you the difference between North Karnataka and South Karnataka. So then imagine North India and South India, right? So we'll have a lot of these kind of very interesting kind of situations to kind of deal with, right? But let's imagine that this child was there in the school, continued another 6 to 8 months later. Also, the child continues with these kind of behaviors, name calling, running around in the school and classroom, getting angry. What would you think at that time? At 6 to 8 months, parents are bringing you after that kind of an initial thing. What are you thinking now? Anything else popping in your mind?
I might be wrong, but what if the system needs to buckle up and be more inclusive and understand
Right.
where the person is coming from?
Right. Definitely. I would love that to happen for a 6-year-old child.
I think it's also
But
important to relate to the duration and intensity. That duration is now more, intensity is remaining the same. So what happened after the principal shouted that it did not work, or what is that?
correct. So we are exploring the history a little bit more in detail, isn't it? Now I've given that 6 to 8 months just so that you guys can understand. But what I'm kind of telling you now, that kind of makes me as a developmental, as a child psychiatrist, look at it that why for this 6 to 8 months also this child has not learned that in school this kind of behavior is not okay. Do you understand what I'm saying? That makes me think, could this child have ADHD? Okay, because we know children with ADHD have difficulties learning from social cues. You understand what I'm saying? Right? So one instance versus multiple instances of similar things happening over and over again, the value that one person attributes to it will be quite different. Right? So this is where I'm saying that we need to learn to look at multiple options of what can be causing. Right? When it is one just some instant like this, we may very quickly dismiss it off. When it is 6 to 8 months constantly not happening, then we have to give it a little bit more time. I'm not saying this is enough to make a diagnosis of ADHD, but I'm saying the mental working of how things happen behind. Okay. All right. I think we are at 4 o'clock. So if I can be here for more questions, no problem. I have at least another 30 to 40 minutes time, but whatever you guys want.
We'll wait for another 2 minutes. If there are no questions, then we may close up. I think in the chat there are people who are giving some reviews as well.
So I'll just start sharing the screen.
Yes.
Thank you.
Yeah, I don't think there are
Yeah,
more
I
questions.
think yeah, there are about 9 of us.
So
Okay.
yeah.
Thank you guys for having me.
Thank you everyone for attending and being there till the end of the session. Thank you, sir, for such an informative session as well.
Thank you. Yeah. Okay.
Thank you.
Bye.